This podcast is sponsored by GSK. Learn more at gskpro.com.
بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. أحييكم مشاهدين ومستمعين ReviveFM Podcast في آخر حلقات الموسم الثاني. بإذن الله تكون حلقة مميزة وتنول على استحسانكم. مثل ما عودناكم في البودكاست راح نطرح ونناقش مواضيع تهم وتخص طب الأسرة. أنا محدثكم دكتور مشعل علي بن حسين R3 Family Medicine at إمام عبد الرحمن بن فيصل University. I would like to welcome our first special guest, Dr. Abdullatif الثنيان, Assistant Professor at College of Medicine and Consultant Family Medicine at إمام عبد الرحمن بن فيصل University. حياك الله دكتور.
الله يحييك وشكرا لكم على الدعوة هذه، إن شاء الله تكون حلقة مفيدة.
And I'm welcoming our second guest, Dr. Manal AlSayar R3 Family Medicine Saudi Board at إمام عبد الرحمن بن فيصل University. أهلا وسهلا دكتور.
شكرا جزيلا، حياك الله.
Also welcome Dr. Omar AlDamegh R1 Family Medicine at John Hopkins Hospital.
الله يحييك، وأنا جدا سعيد صراحة بهذه الفرصة.
وإحنا أسعد بحضوركم، وبإذن الله تكون نهاية الموسم قوية ومميزة بوجودكم معنا. Our episode today is about upper limb nerve injury. Peripheral neuropathy affect up to 8% of cases of general population complain in primary health setting, with higher rates among older population. This topic we face it daily in the family medicine clinic, and maybe one of the challenges how to reach the diagnosis. So, Dr. Omar, what is a neuropathic pain and how it's present?
Neuropathic pain is an unpleasant feeling or sensation that affecting or caused by a lesion or disease affecting the somatosensory of the nervous system. Usually, the presentation of the patient who are having neuropathic pain usually can be burning or shooting pain, or it can be electric sensation like pain, or it could be allodynia, which is a feeling of a pain from light touch. إذا لمسته مثلا يحس بين جدا عالي. or it can be hyperalgesia. من لمسة ممكن بسيطة أو ألم خفيف لكن يحس بألم جدا عالي. And it can be also paresthesia or numbness.
Okay, interesting. Dr. Abdullatif, can you tell us the proper way to approach patient with cervical radiculopathy?
تمام، الله يعطيك العافية. This is a very important question. Approaching patient with cervical or approaching patient with radiculopathy could be challenging because we have many differential diagnoses and many etiologies that we can and we want to identify during the evaluation. We have to be systematic and comprehensive during the physical examination. Starting with analysis of the chief complaint, we have to identify the location and distribution of the pain. Because this will help us identify the location of the injury and the extent of the injury, identifying the character of the pain, identifying the mode of onset. Is it acute? Is it subacute or chronic? Because many conditions can differ based on its time of onset. We have to inquire more about the mechanism of injury. How did the pain started? Is it because of a trauma? What is the mechanism of a trauma? Or it is because of repetitive movement, or there is unclear mode or mechanism of injury that could lead us to think about more of degenerative conditions. There are many conditions that can be identified by knowing the aggravating and alleviating factors. So it's very important to ask about this question. Example for that, we know that carpal tunnel syndrome pain increases at night and increases with wrist flexion. Other types of pain can increase or decrease with different mechanisms. We have to inquire more about the associated symptoms. For example, swelling, pain elsewhere, reduced function, weakness, or vascular compromise. This helps us to identify the cause as well as identify some important consideration like vascular compromise for the limb. Now we can go for some risk factors.
Like what?
Many conditions has risk factors like obesity, like excessive use or overusing the limb. Some other risk factors like malalignment of a limb, or medical conditions like diabetes, hypothyroidism, vitamin B12 deficiency, surgeries, and using of medications which can lead to a neuropathic pain. After finishing the history, we can have a list of differential diagnosis. It's important to have your list of differential diagnosis. Don't jump to one diagnosis before going to physical examination. Having said that, we have to ask the patient as well what is their idea about the pain and what is their expectation about the management of this visit. Now we can go to the physical examination. Physical examination should be comprehensive, focusing on neurological examination and local examination, looking for compromising mass, for swellings around the site of the injury. Starting with the neurological examination, we have to examine from the cervical spine to the fingers. We have to look for the sensation, reflexes, and bowel examination. For some condition, we have special tests. We can look for like tunnel tests and the axial compression test for the radiculopathy. Having done all the history and physical examination, we can now narrow the differential diagnosis. Then we can use one or more of the diagnostic tests to help us to identify the most likely diagnosis. Sometimes we need to request for nerve conduction study. This will help us to identify the exact location of the injury as well as the severity and the prognosis of the injury. Sometimes we need to do diagnostic imaging like an MRI or ultrasound in case of an extremity condition, so to localize any compressing ganglion cysts, lipoma, or tendinopathies.
Clear.
Yes, this is much of it.
No, thank you, Dr. Abdullatif. Dr. Manal, we face a lot of cases of cervical radiculopathy in the clinic. How do patients with cervical radiculopathy usually present with?
صحيح. هذه الكيس نشوفها كثير في العيادات. Usually patient with cervical neuropathy will present with neck pain in addition to a sensory loss and weakness for neck, shoulder, arms and hands. But these symptoms varies depending on the damaged nerve root.
Can you tell us please how we usually reach the diagnosis for cervical radiculopathy?
أكيد. طبعا دكتور عبداللطيف, he already mentioned that taking a proper history is essential for diagnosing cervical neuropathy, as well as physical examination. Usually patients with cervical neuropathy will present with a restricted range of motion of the neck. بيكون عندهم sensory loss and weakness. It varies طبعا per nerve root damage. One of the most common nerve root injury is C7. Usually لما يكون في damage في هذا النيرف راح يكون عنده weakness في extension of the triceps, extension of the fingers and flexion of the wrist, as well as sensory abnormalities in the middle finger. With tricep reflexes usually diminished in this patient. Furthermore, في برضو اللي هو special test that we can use to diagnose cervical neuropathy زي Sperling test. Usually we do an extension of the neck, lateral rotation, and apply axial pressure. And if this aggravates or provokes the symptoms, then it's positive. طبعا the gold standard to diagnose cervical neuropathy is clinical. However, there are indications to do an MRI. MRI will give us an adequate visualization of the soft tissue and the damaged nerve root. إيش هي indications? إنه يكون عنده significant or progressive neurological deficit. يكون عنده symptoms that persist despite conservative treatment. أو إن الدكتور أو الphysician يكون عنده concern about an underlying condition زي tumor, infection, or myelopathy.
So for the diagnosis, usually the physical examination and the history, it's the main things, and the confirmed diagnosis will be with the MRI.
فعلا صحيح.
ممتاز. Okay, moving to you, Dr. Omar. What would be the appropriate management for this patient?
Well, يعتمد على how severe the case is. We can offer the patient 3 options. Non-pharma way of treatment, pharmacological way of treatment, and at the end maybe surgical. For example, as non-pharma, we advise the patient to rest and activity modification. For example, avoid heavy lifting and avoid prolonged sitting. We advise patient to increase or to follow physical therapy program. This will help much. Lastly, we can offer cervical collar to stabilize the cervix and to avoid mobilization. For pharmacological way of treatment, we have some medication we can offer the patient, starting with non-steroidal like Brufen, to reduce the pain and to reduce the inflammation. We can offer also oral corticosteroid for acute severe pain. We can offer muscle relaxant to reduce the muscle spasm if there is. Or we can give gabapentin or pregabalin if there is any neuropathic pain. Lastly, we can, if there is any failure of the previous medication mentioned, we can offer surgery if there is persistent pain that lasts more than 4 weeks, or we can suggest surgery if there is any significant muscle weakness.
شكرا دكتور عمر. Dr. Abdullatif, how does brachial plexus injury presentation differ from cervical radiculopathy?
Thank you. This is very important question. The brachial plexus injury can be confused with the cervical spine injury or radiculopathy, but it is essential to identify the key differences between them. Number one, the brachial plexus injury usually present with widespread distribution of a neurological deficit, because it can affect multiple levels of cervical spines. Therefore, you can have sensory deficit at multiple levels, and you can have motor deficit at multiple levels. In contrast, the cervical radiculopathy, the injury usually follow a certain dermatome and myotome distribution. For example, if the injury at C7 disc, therefore the distribution will be weakness of triceps extension, weakness of the wrist flexion, finger extension, and sensory deficit corresponding to C7, which is middle finger. However, if there is brachial plexus injury, the distribution will be different and does not follow the dermatomal or myotomal distribution. Second thing to consider is the mechanism of injury. Speaking about the cervical radiculopathy, as Dr. Manal said, the most likely causative etiology for this condition is degenerative. It could be acute, but it's acute disc disease. In contrast, the radiculopathy, the most likely etiology is trauma, either traction trauma or compressive trauma to the brachial plexus. It's also to remember that there are many other causes could be dangerous, like tumor compressing on the brachial plexus, thoracic outlet syndrome, cervical rib, or plexus neuritis. Please consider these differential diagnosis in evaluating patients with radiculopathy.
الله يعطيكم العافية دكاترة. أعزائي المشاهدين والمستمعين، كذا وصلنا لنهاية الجزء الأول من الحلقة. فاصل ونرجع لكم.
Shingles is a painful disease that can have serious and long-lasting complications. And the burden of shingles increases as the person ages, with a steep increases in adults above 50 years due to age-related decline in immunity. Shingles vaccine can provide up to 90% protection against shingles. Saudi Arabia's Ministry of Health recommends 2 doses of shingles, 2 to 6 months apart, for all adults ages 50 years or older in their national immunization schedule.
رجعنا لكم مع الجزء الثاني من الحلقة. Now let's move to another important topic, which is peripheral neuropathy. Dr. Abdullatif, the most common upper limb peripheral neuropathy is carpal tunnel syndrome, which is a compression of the median nerve at the wrist joint. Can the median nerve be injured above the level of the wrist, and how can we differentiate it between carpal tunnel syndrome from other injuries?
Yes, this is very smart questions, because I identify many residents that have difficulties in identifying conditions other than the carpal tunnel syndrome, which affect the median nerve.
Mm-hmm.
Median nerve can be affected by other reasons, and this will be high median nerve injury. Okay. First of all, we can differentiate between these conditions by history, physical examination, and maybe diagnostic testing. Let's mention the sites. The second most common site of median nerve entrapment is the pronator teres syndrome, which is entrapment of the median nerve at pronator teres muscle, which is a pronator of the forearm. This is common in tennis players and in athletes who excessively or repeatedly pronate their forearm. Therefore, this can be swelling and tendinopathy. Therefore, it can compress the nerve. It can be compressed higher, below. In the lower third of the humerus or distal humerus, and it can, to some extent, give the same picture of the pronator teres in terms of distribution of nerve, of sensory and motor deficit.
جميل.
Okay. The third location is below the pronator teres, where the motor branch go out into anterior interosseous nerve, which is purely motor. Therefore, with this injury, you will not see any sensory deficit. How to differentiate between pronator teres syndrome and carpal tunnel? Pronator teres syndrome, there is also sensory deficit in the palm area. In contrast with carpal tunnel, this area will be spared. Number 2, the pain will be exacerbated by tunnel test at the pronator teres muscle. If you percuss on the pronator teres muscle, this can reproduce the pain. Also, by palpating the muscle, it can yield a tenderness over the muscle. The pain will be exacerbated by forcefully pronate the forearm or pronate and extend the elbow. In this manner.
Interesting.
Okay. The carpal tunnel, we all know that there are special tests that are very helpful and have good diagnostic yield for carpal tunnel. The most sensitive test for carpal tunnel is carpal compression test, called also Darkins test. This has high sensitivity. Second will come the Fallon test and tunnel test at the wrist. The most specific sign will be the flex sign for the wrist, where the patient describes relieving of the pain after flicking the hand. Let's go for the anterior interosseous nerve. Anterior interosseous nerve will have only motor deficit, and the motor deficit will be much more severe than the carpal tunnel, because it can affect widespread musculature of the hand before it enter into the carpal tunnel. Therefore, you can see something called inability to do OK sign. The patient will not be able to oppose the index into the thumb. Therefore, there will be weak OK sign, or patient will not be able to do OK sign. Number 2 is an Abe hand sign. The patient will not be able to abduct the thumb. The thumb will be abducted. You can observe a thinner atrophy. This can happen also in the low median nerve injury, but it will be less severe than high median nerve injury. The third sign is the sign of benediction, where the patient is unable to flex the index, the thumb, and will be partially flexing the middle finger. The sign will be like this. If you ask the patient to do a fist, he will be doing like this.
Mm-hmm.
This indicates a significant median nerve injury and most likely will be above the wrist. Okay.
Mm-hmm.
This basically how to differentiate between median nerve below the elbow and median nerve at the wrist area.
جميل.
يعطيك العافية دكتور
الله
عبداللطيف.
يعافيك.
واضح والله.
يعني إذا فهمتك صح, the diagnostic value of these special maneuvers في the examination of carpal tunnel syndrome, the median nerve compression test is the most specific and the most
median nerve compression test is the most sensitive
test.
Yeah.
مقارنة بالother test زي التنل والفالن.
test.
Okay.
يعني بعض الأحيان أسأل الريزيدنت أقول لهم what is the most sensitive test, فيقولوا لي الكاربال compression test. فأقول لهم لا, طب أنت كنت تقول كذا. أقول لهم أنا أسويها مع فالن test. I compress and do also a flexion
of the wrist. تمام.
Yeah, this will add the effect of two tests together, so this will yield a better result.
حلو, خذيناها تكنيك الحين. we can combine two tests بتست واحد.
You can combine, you can do some flexion with compression. Okay, this will give a better result than only one of them alone.
طب دكتور, أنا كذا وصلت كذا جاني سؤال, النيرف كوندكشن studies when can be performed?
Nerve conduction study في الcarpal tunnel syndrome is one of the important modality for diagnosing the carpal tunnel syndrome. Also, it's helpful to highlight the prognosis of the condition and identify the indication for surgery. يعني هو مهمة not only for diagnosis. Okay. في حالات moderate to severe carpal tunnel syndrome, it is essential to perform nerve conduction study to identify the extent of the injury to the nerve, to identify if there is axonal degeneration or denervation of the muscles. In these cases, the surgery will be indicated.
الله يعطيك العافية دكتور عبداللطيف على إسهابك في الإجابة. دكتور عمر, can you tell us what are the surgical and non-surgical option regarding management of carpal tunnel syndrome?
اوكي. بالعاده صراحه نسال احنا البيشنت وش هو يفضل. بعضهم ممكن ما يفضل شيء ومرتاح, وبعضهم لا, ممكن والله يحتاج تدخل ويطلب منك يعني مساعده. لكن ممكن احنا عندنا نون سيرجيكال اوبشن وممكن عندنا سيرجيكال اوبشن. نون سيرجيكال اوبشن اول شيء انه ممكن نعطيه ريست سبلنت. This considered as the first line of treatment. ممكن يستخدمها وقت الليل, خصوصا وقت النوم, لأن بعضهم ينامون ويصفط يده مثلا بالغلط, فمجرد يقوم الصباح يشوف إنه فيه سيفير بين وتتكرر أكثر من مرة, فما راح يشعر بأي تحسن. ممكن advise the patient to activity modification. مثلا الناس صراحة اللي يشتغلون بالمكاتب كثير ممكن في أشياء معينة يغيرونها, مثلا الماوس يقدر يغيره أو الكيبورد, just avoiding the triggers. آخر شيء ممكن صراحة corticosteroid injection إذا الأعراض كانت تقريبا من 6 أسابيع إلى تقريبا 3 شهور ما تحسنت, ممكن we give يعني corticosteroid injection. As a surgical option, we can do carpal tunnel decompression. متى؟ إذا conservative management failed, أو ممكن إذا صار فيه أي nerve damage.
يعطيك العافية.
ممتاز, الله يعطيك العافية.
دكتور عبداللطيف, what are the physical signs that we might face in patient with radial nerve injury?
Thank you, Dr. Mishal, for this question. This is very high yield information about the radial nerve. The radial nerve can be injured at 3 or more than 3 different levels. Let's take, for example, very high radial nerve injury, which is injury at the axilla, the high radial nerve injury, which is injury at the mid-humeral shaft, specifically around the spiral groove, or low medial nerve injury is injury of the posterior interosseous branch of the radial nerve below the elbow. The fourth one is injury to one of the sensory branch, which is the superficial radial nerve branch just before the wrist. And this area exactly, this can only supply the sensation of the dorsum of the hand. Let's go up. Very high radial nerve injury can happen because of a crutch palsy or a fracture or dislocation in proximal humerus. The motor deficit can affect the extension of the hand. I mean the triceps function. Going below at the mid-humerus, the triceps function will be normal. The brachioradialis will be affected, and the extensors of the hand, wrist and fingers will be affected. Going below the elbow, the extension can be weak, but less affected than the above the elbow injury. But the finger extension will be affected. Remember, the posterior interosseous nerve is only motor nerve. There is no sensory branch. So if you have sensory deficit, it should be above at elbow or above. Okay, you got it?
Yeah.
Sometimes we need nerve conduction study to differentiate or to identify the exact location of the injury.
الله يعطيك العافية.
جميل.
برجع لك دكتورة منال. Can you please talk briefly about ulnar nerve? How does the injury of this nerve present? And does the location of the injury affect its presentation? I mean, proximal versus distal?
It does actually. طبعا ulnar nerve injury can happen in two different places at the elbow level, and it's called a cubital tunnel syndrome, or it can happen at the wrist level, which is called the Guyon's canal syndrome. Usually, if it's at the elbow level, patient will present with numbness and tingling in the 4th and 5th digits. There will be a medial elbow pain, as well as numbness and paresthesia at night. If the injury is at the wrist level, usually the patient will present with muscular atrophy, hand weakness, grip weakness as well, and their claw hand will be more severe.
Excellent. It's important to identify that the ulnar nerve, I will add to Dr. Manal, it's help in the ulnar deviation.
صحيح.
Flexion and ulnar deviation. This will be affected with high ulnar nerve injury.
At the elbow level.
However, with low ulnar nerve injury at Guyon's canal, this will be spared. Okay.
صحيح.
The claw of the hand can happen either at the elbow or the injury at the wrist.
صحيح.
But injury at the wrist,
it's more severe.
It's more severe, not because it affects more muscles, because it affects less number of muscles, because the opposing muscle is working. Therefore, the clawing will be more obvious.
صحيح. يعطيك العافية.
Last thing to add is the tunnel test. If you percuss over the cubital tunnel area, this can reduce the pain for cubital tunnel syndrome.
طيب Dr. Abdullatif, you mentioned at the beginning of the podcast the electrodiagnostic study has valuable role in patient with peripheral nerve injury. How can this modality be helpful in patient with peripheral nerve injury?
طيب, the nerve conduction study is very important and critical in evaluating patient with peripheral neuropathy because it has three main benefits. Number one, it can identify the location of the nerve damaged. It can identify exact nerve damaged, and it can identify the severity and therefore the prognosis of the nerve injury. First one is neuropraxia, which is the less severe one. This happened because of compression, which is reversible, and the prognosis is good. The patient usually regain the function of the nerve after removal of the compression within days, 2 weeks. Number two is the axonotmesis, which is degeneration of the nerve with preserved connective tissue surrounding the nerve. The connective tissue surrounding the nerve will help in regeneration of the nerve, and the regeneration process and regeneration speed will depend on the distance of the nerve from the end point to the nerve, to the nerve ending. Okay.
Mhm.
The prognosis is worse than first one, but better than the last one. The patient can have months to recover, and this will be based on the extent of the injury. The last one is axonoatmesis. Axonoatmesis means death of the nerve and the connective tissue surrounding the nerve, and this will have the worst prognosis, and patient may not recover after injury unless the intervention happen very, very early with expert neurosurgeon.
شكرا لك دكتور عبداللطيف على هذه الإجابة، كانت حلقة ممتعة. قبل ما نختم دكتور, is there any home message you would like to share with our colleague in family medicine regarding neuropathy?
العفو، الله يعطيك العافية، بارك الله فيكم. الرسالة the evaluation of the patient presenting with neuropathies could be challenging. Therefore, try to be systematic and comprehensive in evaluating these patients. So be systematic and be comprehensive.
بإذن الله إن شاء الله.
يعطيك العافية أبو خالد، ما قصرت.
الله يعطيك العافية.
شاكرين ومقدرين حضورك وإثراءك بالمعلومات.
الله يعطيك العافية والله يبارك فيكم، وشكرا لكم على التحضير وشكرا لكم على التنسيق. بارك الله فيكم جميعا.
والشكر موصول لك دكتورة منال، الله يعطيك العافية، أكرمتينا بحضورك والمعلومات اللي أعطتنا إياها.
شكرا لك دكتور مشعل، شكرا دكتور عبداللطيف على المعلومات اللي أعطتنا إياها، فعلا حلقة كانت غنية بالمعلومات. وشكرا طبعا للجمعية السعودية لطب الأسرة والمجتمع وفريق ريفايف اف ام.
الله يعطيكم العافية. دكتور عمر كمان ما قصرت، عارفين كان شورت نوتس لكن الله يعطيك العافية ما قصرت.
الله يعطيك العافية، بالعكس أنا جدا سعيد صراحة بهذه الفرصة، وأحب أشكر صراحة الجمعية السعودية لطب الأسرة والمجتمع، وأحب أشكر برضو الدكتور عبداللطيف الثنيان على جميع المعلومات القيمة اللي استفدناها خلال هذه الجلسة. سعيد والله بهذه الفرصة.
أنا أسعد.
الله يحييك.
الشكر موصول أيضا لفريق ReviveFM بودكاست من اللجنة العلمية واللجنة التنظيمية والإعلامية، ما قصرتم جميعا والله يجعله في ميزان حسناتكم. هذا البودكاست يقدم لكم برعاية الجمعية السعودية لطب الأسرة والمجتمع. لمزيد من المعلومات عن الحلقة تجدونها في صندوق الوصف أسفل الشاشة. لا تنسوا التعليقات وتشاركوا هذا الفيديو للجميع لتعم الفائدة. وتذكروا دائما إنما الإنسان أثر فأحسنوا مآثركم. فأمان الله.
This podcast is sponsored by GSK. Learn more at gskpro.com.